Okay, thanks, Julie. Thanks, everybody, for coming. I'm going to jump right in because I think we've got a lot to cover, and I want to make sure leave enough time for Gabby. So this will be a whirlwind tour through the work that we've been doing on psilocybin-assisted treatment for alcohol use disorder, focusing on the quantitative outcomes from our recently completed double-blind trial. And then Gabby will give us some more personal perspective from a qualitative study that we've completed in participants from the same trial. So these are my disclosures. Research support, some advisory boards that I'm involved in and consulting. So this, people have seen this slide probably a dozen times, but just to remind everyone, there was a considerable body of research on psychedelics for a number of conditions, alcohol use disorder first among them. And although at the time and for decades afterwards, those results were considered to be highly equivocal, a meta-analysis that was published in 2012 indicated that there was a really pretty robust, consistent effect across the 6 controlled trials that had been done with LSD to treat alcohol use disorder with an overall odds ratio of close to 2 for the first completed follow-up visit, and effects persisting for at least 6 months. The first study with psilocybin to treat alcohol use disorder was the one that my group completed when I was at the University of New Mexico with 10 participants, 2 psilocybin sessions, and this was just a single group, uncontrolled pilot study to demonstrate feasibility and see how people did. And so we did observe some improvement. Just if you look at the shape of the curve, this is percent heavy drinking days, which is just for future reference, that's 5 or more drinks for a man in a day, 4 or more drinks in a day for a woman. And so this is the percentage, how many days out of 100, or dividing total days that are heavy drinking days divided by the total number of days in the period. So there was some improvement in the first month when the participants were receiving psychotherapy but hadn't received psilocybin yet, which you see between the first 2 points there. But after the first psilocybin administration session, their drinking decreased dramatically, and that improvement was maintained over the entire follow-up period out to week 36. So this looked good. There were no safety issues that came up, and it was promising that that improvement happened after they were already improving from the therapy and then persisted for all those months. So the trial, on the basis of that pilot study, we designed this randomized controlled trial, and I'll take you through the design of it just as quickly as I can. So we ultimately randomized 95 participants, adults up to age 65, and they received 2 double-blind sessions with either psilocybin or diphenhydramine, which we can talk later if there's time, if people are interested in why we selected that control condition. So 2 double-blind dosing sessions a month apart with 12 weeks total of therapy, starting 4 weeks before and ending 4 weeks after the 2 psilocybin sessions, which were 4 weeks apart. And there was also an optional open label session at the end of the double-blind phase, which we won't talk about today. But the psychotherapy, as I mentioned, 12 sessions over 12 weeks, and it was a combination of just elements of evidence-based treatments for alcohol use disorder, motivational enhancement therapy, and particular formulation of cognitive behavioral therapy focused on skills training and sort of decisional analysis. And then the psychedelic-focused content, which was probably would be familiar to everyone here, fairly standard preparation, rapport building, support, non-directive interaction during the session, and processing integration afterwards. So 12 sessions total. The medication sessions, 8-hour sessions, team of 2 therapists, and psilocybin dose in the first session was 25 milligrams for 70 kilograms, so it was weight-based. And in the second session, it was increased to either 30 or 40 milligrams per 70 kilograms, depending on the intensity of the experience in the first session. I'll show you a little bit more about that later. And then, the diphenhydramine control, it was 50 milligrams and 100 milligrams in the first and second sessions, respectively. And that's a fairly sedating dose, but not usually one that causes hallucinations or anything like that. Overall, these doses of psilocybin produced the robust subjective experiences that we would expect. And the MEQ total scores for both sessions for the psilocybin participants were about 60% of the maximum possible score. And this slide is just to show within the psilocybin group, those we divided people into those who had a low level of response in the first session and those who had a more robust response. So you can see the green line, those are the ones who had low scores in the first session. They got the higher dose, 40 milligrams per 70 kilograms. In the second session, and that brought their scores up pretty close to the others. And then most of the participants got 25, as I mentioned, in the first session and went up to 30, and their scores stayed about the same. So the dose titration seemed to work pretty well. But just remember that the people only got 40 milligrams per kilogram if they had a relatively mild response in the first session. So that's why they were able to tolerate the high doses. And this is just sort of the punchline from the study. This is the paper that we published in JAMA Psychiatry in August. And the primary outcome was % heavy drinking days. And you can see, like in the pilot study, both groups, psilocybin in red, control in blue, both groups decreased their drinking substantially in the 4 weeks prior to receiving psilocybin, when they were receiving those first 4 psychotherapy sessions. After receiving the first medication session, the psilocybin group improved much more, and you can see their heavy drinking days remained lower, substantially lower than the control condition over the entire follow-up period, again out to week 36. So this was statistically significant result, and the effect size was a very solid 0.52 using the standardized effect size HSG, which is much larger than we've seen for any of the available treatments for alcohol use disorder, and if you look at meta-analyses for them. If you look at dichotomous outcomes, these are a little easier for many people to understand, or just to get a handle on what it means clinically. So we looked at a number of different pass-fail kinds of outcomes. So if you just look at abstinence, the second row, abstinence in weeks 33 to 36, that's the last month of follow-up, 7 months after their second dose of psilocybin versus diphenhydramine. 48%, almost half of the psilocybin-treated participants were abstinent during that month versus 24% in the control condition. So 2 to 1, and that's an effect that's persisting over 6 months after the last dose of study medication. So I want to take you through a few secondary outcomes, and this will hopefully sort of lead into the more nuanced information that we'll get from the qualitative analysis. This is a set of the problem index, so overall problems related to alcohol from beginning to end of the double blind, and both groups improved, but again, much greater improvement in the psilocybin treated patients. This is a craving score, pen alcohol craving score. And again, you see a nice separation between the two groups, which, if anything, increases over time. So this is highly significant as well. And this is another sort of craving measure, temptation to drink alcohol in a number of different situations in this alcohol abstinence self-efficacy scale. The other subscale of this AASE is the confidence subscale. So that's rating how confident are you that you would be able to resist drinking in various high-risk situations, like you're passing your favorite bar, or you get into a fight with your significant other or your boss or whatever. So again, the confidence was much higher in the psilocybin-treated individuals. Self-compassion, which is something Gabby will touch on in her presentation, improved dramatically in the psilocybin group and really did not seem to change much at all in the control group. And again, those effects, if anything, increased over time. And we also replicated some of the findings of previous studies in terms of personality changes with psilocybin. The psilocybin-treated individuals had significant decreases in neuroticism, increases in extroversion, agreeableness, and conscientiousness. And if we looked at the subscales within those dimensions to get a better sense of what we're talking about here, within neuroticism, the decreases were primarily in depression, impulsiveness, and vulnerability, emotional vulnerability, that is. Within extroversion, it was really driven by positive emotions. So this is, relevant both to alcohol use disorder and to mood disorders, obviously. And in terms of openness, it was openness to fantasy and to feelings. So this may correlate with self-compassion or mindlessness and ability to, observe non-judgmentally. We'll try to understand in future studies exactly what's driving this. And then under conscientiousness, deliberation, which is, has to do, again, it's related to impulse control and thinking rather than acting reflexively. So those were some of the principal findings. Obviously, we have a lot more work to do, and I didn't even touch on the subjective experiences, which we'll talk about in future presentations and publications. But overall, the efficacy outcomes, I think, were very encouraging, robust, persistent, larger than those of currently available treatments. And these psychological outcomes really support, at least give us ways of understanding how this might be working in alcohol use disorder and why we see psilocybin having this transdiagnostic therapeutic effects across mood disorders, probably anxiety disorders and addictions as well. So moving forward, we will be launching early next year a multi-site trial sponsored by BMOR. And I see Carrie Turnbull and Claudia Turnbull sitting here, and I want to thank them for their support, for the prior work and just for moving the field forward, in so many ways, and their incredible contributions. So we'll be launching this trial and hope to use that as one of the two pivotal trials in support of the AUD indication for psilocybin. So I'm done with my part, and I'll hand it over to Julie for introduction.
Thank you, Dr. Bogenschutz, and yes, thank you, Claudia and Carrie Turnbull, for your amazing support in this field. Our next speaker is Gabby AGIN-LIEBES, PhD. She is a NIDA T32 Research Fellow at Neuroscape at the UC San Francisco and is a licensed clinical psychologist, having over a dozen years of experience working as a therapist and investigator on academic clinical trials with psychedelic therapy at NYU, here at Yale, and at UCSF. Dr. AGIN-LIEBES.
Hello, everyone. Can you hear me back there? Yeah? Awesome. Okay, great. So I am very excited to be here to present on the qualitative findings that accompany the study that Michael just presented, and we just submitted our manuscript for review, so it's currently in a journal, under peer review in a journal. But you get to see the findings, before they come out, so that's exciting. And I'm going to focus on, we had several findings, but I'm focusing today on self-compassion as a key mechanism of change in the treatment of psilocybin-assisted therapy for alcohol use disorder. And I'm going to kind of provide some context to support this idea that self-compassion can transform shame and self-criticism into a kinder and more compassionate way of being with oneself. So what is self-compassion? Self-compassion originally is a Buddhist concept that refers to directing compassion to all living beings, and that includes oneself. And so it's an important foundational part of the practice. And this recognition that all humans are imperfect and make mistakes. My personal definition of self-compassion also includes this embodied, empathic sense of connection to oneself. And why is this important for this population? So not just with individuals with substance use disorder. There's a trans-diagnostic kind of, I seem to think about like almost a crisis of shame and self-loathing that can explain a lot of different, mental health issues, but specifically, or especially within substance use disorders and alcohol use disorders, this is very relevant. Oh, sorry, I didn't advance to the slide. And so research methods. So we we interviewed 13 participants in the trial, so just a small subsample of participants who had finished the study. And the interviews took place ranging from about 10 to 75 weeks, so there's a large range in between when they were interviewed. And my collaborator, Elizabeth Nielsen, and I developed the protocol, and we were aiming to really understand the lived experience of participants going through this study. So from their perspective, and the method that we use called IPA, Interpretive Phenomenological Analysis, really is aiming to get to that sort of richer, how people make meaning of their experience. And so here's a sample. I'm not going to go through all of these, but we had a lot of interview questions, and they focused on participants' relationship with alcohol before the study, during the study, and then kind of in the longer term phases of their treatment. And you can see here, we asked specifically, how has your relationship with alcohol changed over time, and your experience of different elements of the study. So in the interest of time, I'm not going to go through all the demographics, but what I do want to point out is that nearly 2/3 of the participants in at least this sample of the study, I'm not recalling exactly how many in the larger parent study, but almost 2/3 of participants had family members who struggled with alcohol misuse. And I'll kind of weave that in a little bit for more later. Okay, so this slide I'm going to spend a little bit of time on because it really is the meat of our findings. So you'll see here we have a table with categories, there's nine themes, and divided across temporal, before, during, and after. And I'll start with the top on the left. So awareness. Is this animation working? There we go. So awareness refers to being present and paying attention to one's sensations and thoughts. And before psilocybin session, or before the treatment, the participants really reported struggling to, really struggled to manage stress, manage negative emotions, and alcohol really was effective at self-medicating or soothing these painful affective states. And it really became a habit of avoiding negative emotions or avoiding stress. One participant noted, I would go into this zombie mode. I would just drink, I would smoke, I would eat, kind of numbing out. The next here in intrapersonal, which refers to one's relationship with oneself, which is what I'm focusing quite a bit on today with self-compassion, and I think really is the vehicle for all these other themes, is shame and self-criticism. So these participants, all participants reported substantially intrusive, ruminative thought processes about themselves. So self-blame, guilt, shame, and many described that they had kind of adopted or internalized the voices of their caregivers or like other perpetrators of trauma, the various traumas they had endured. And they had like adopted the voices of their, these either parents who had been unresponsive or invalidating. And so here, my inner voice was constantly undercutting me. And it left them with this overactive threat system, unable to soothe themselves, and they felt very unsafe in their bodies. And then alcohol is a surrogate for connection. So over time, they felt disconnected, especially as they began to really get sort of deeper into the throes of their addiction. And it wasn't uncommon for them to describe alcohol as a friend, actually even a very close friend. So it was a real substitute for friendships and real friendships. And then during psilocybin, so this is like acutely, we asked them, how did you experience, or what was your experience during the psilocybin session? And so psilocybin appeared to, or they reported that it evoked intense emotions, so catharsis, releasing a lot of emotions that had been stuck, and then also gave way to this like spacious clarity that's commonly reported in studies with classic psychedelics. So being able to see the bigger picture, letting out all the pain, taking the barriers down. We also know that psilocybin, in addition to producing this like spaciousness and this kind of mental clarity, it can provide this experience of connectedness, so this like positive mood, connectedness, and this expansive sense of unity, and they kind of co-arise. And so what was interesting is that participants really connected this experience and were able to find a way of relating to themselves and to their alcohol use and to their past in a very, in a much more friendly way. One participant saying, I felt tenderness for myself. So the sort of beginning, we called it self-compassion template. And then interconnectedness. So again, unity, this mystical unity, feeling this sense of connection with themselves, with others, with the world, with the cosmos, and really feeling like a sense of belonging where they had felt pretty separate before that. Someone said, this endlessly deep interconnectedness and endlessly loving force. And then after psilocybin, so in the long term, and as Michael showed with the self-compassion graph, we see this self-compassion endure. And so that's an interesting finding, and the qualitative narratives we have seem to give us some insight into why. So after their sessions, people reported that they felt more patient, more able to be with emotions as they arise, and to kind of allow them to fall, not be overwhelmed by it, awareness that the emotions will pass, rather than holding on to them. And then in the self-compassion template that kind of was accessed during the psilocybin session began to get kind of incorporated into their practices, and coupled with this mindfulness, but it was more than that, more than just mindfulness. It was being able to, love themselves and build this sort of inner resources that they could access, this kindness, rather than kind of self-punishment. And then the last one is secure base and belonging. So, empowered with this kind of self-compassion, self-love. They felt more empowered to ask for support, and their relationships improved. They were able to trust other people, express gratitude, forgive others, forgive themselves, and they felt more confident in the world, and in themselves. So now I'm going to dive a little deeper. I don't have time to go through all the quotes, all 9, so I only have a few here, but I wanted to showcase a few that I think are really special. So here we have self-medication, surrogate for connection. So alcohol was a friend. It helped me, but then I got to see that it's not really the friend that I thought. It provides like an hour of relief, and then there's 23 hours of recovery. This friend, it's really not a friend anymore. So, it's really important to emphasize that, we could think of whatever the substance is, and here in this case, alcohol, as this maladaptive coping. But for many people, it is a really useful way to cope with the pain that they're experiencing. So when we think about treatment, we really want to consider how to support people in building up support systems so that we can kind of replace this, in this case, alcohol with real and supportive relationships. And then here, acute interconnectedness. This is another one. I wasn't even having thoughts, just in a state of connection. I remember going back to being before I was born. I felt like I chose this human body in order to carry out the work I came here to do in this lifetime. I saw it all perfectly orchestrated, even alcohol as part of it. I think we need these substances to help us remember our place in the world. So I'll do a time check. Okay. And then I touched on this a little earlier, but drinking, shutting off the voices. So the voices that had been internalized from their upbringing and their parents. And in the interest of time, I'm not going to read this quote out loud, but as you can see, it really demonstrates how much the self-critic became sort of deeply embedded in their consciousness. And then another quote about self-compassion template, having compassion for everything I've ever done. This is during the psilocybin session, making sense in a bigger way. And then in the long term, being able to regulate with self-compassion and use that as like a strategy, emotion regulation strategy, and not identifying with the shame, but being able to kind of let it pass through and recognize that it's a human experience. So here, I just want to, just emphasize that self-compassion seems to be this kind of like the linchpin and the vehicle for these other 2 dimensions of awareness and interpersonal. And from the key thing here is that, this unity and connectedness that people had experienced during the session with the support of their therapists. I want to really emphasize that really was important for reinforcing safety, connection, compassion for themselves. But really, without this relational component, so having mindfulness is helpful to become aware of your suffering, or aware of the struggle, aware of the patterns that aren't helpful, but to be able to relate to yourself with compassion really enables you to sustain recovery, because you're not beating yourself up, you're able to see that you're human and able to kind of actually approach emotions rather than avoid emotions, and trust that it's a human process. And so, future questions. So Michael and I, Michael and our team, we're working on a analysis of the self-compassion data with more with deeper analysis, looking at relationships between mystical experience and drinking outcomes. And we are also interested in how do we harness this mechanism of self-compassion? Are there interventions that already exist that use self-compassion more directly that can synergize well with psilocybin? And also curious about taking what we've learned here, applying it to other areas like attachment in terms of relationships, and how self-compassion might be shaped by early attachment relationships. And then beyond the clinical research, this deficit that we have, especially in the West, in self-compassion. We have a rugged individualist society and kind of a crisis in self-loathing. And so when we can't connect with and feel compassion for our own feelings, we may lose our ability to feel compassion for others. And when this occurs, we might act out in violent ways. And I think this might be sort of the root of a lot of the destruction we are seeing today. So just to end on a quote, which how are we doing on time? I know we are basically wrapped up, but I'll let you read this quote. I think it's so beautiful and just captures in this beautiful way and shows how psilocybin can create this felt, embodied experience of relating to oneself with compassion. So this woman opening the fridge and, petting this alcohol weasel, calming it down and treating it lovingly, I think it speaks for itself. And thank you so much for your attention today.
Thank you, Gabby. I have a question for both of you, and I imagine I'm not the only one in the room who has this question. As a matter of fact, it came up on the Q&A quite a bit and got upvoted, but it's this idea of whether you need the spiritual/mystical component to have some behavioral change.
Well, I guess I can say, just in terms of, we definitely had participants who did not have that kind of experience and had remarkable behavioral transformation. So I think there's no question that that can happen. So the broader question is, to what extent is it a part of how and why these treatments work? And I think we all, the participants tell us it's key. It looks like that. I think it really has not been convincingly demonstrated to this point, and empirically at all. And it's a challenging thing to do because of the obvious issues with blinding, and there's no real control group that you can give where people get the drug and they don't have the experience and to look at that. So I don't know. I think it's it would take fairly strong evidence, very strong evidence, to convince me that it's not important, but I don't have any strong evidence at all to say that it is important either. So I think we're just getting to the state where we're having large enough trials. We'll certainly look at that very closely in this study, but I'm not ready to say what that is because we just don't know yet.
Gabby, you have an opinion on this?
Well, you can all hear me still?
Yeah.
Is that right? As a psychologist, I'm a little biased towards the subjective experience, at least when we think about long-term change and behavior change, which is so hard to do. It's just, we as Michael said, we really don't know a whole lot. There's clearly a biological component, but for sustained change, I do think there has to be some shift in the way that a person experiences their suffering or their whatever is bringing them to this process of therapy and healing, and to take some ownership over that process. And so maybe it doesn't have to be a mystical experience, it's sort of spiritual experience, but something that's personally meaningful that allows them to sort of shape the way or reshape the way they think about themselves and in the world.
I'm sorry if I missed this, but it's a question coming up. Did you measure motivation, and was that a factor?
You did.
The issue is that motivation was uniformly very high in this group. So we didn't. There's not enough variance to really know about that. But people who wanted to be abstinent, people who wanted to cut down, both seemed to benefit. It's a different kind of motivation. So I would not, and I would not assume that you'd see similar results if you dragged somebody in off the street and said, you've got a problem, take this.
Yeah. Can either of you talk about whether there were some people who just didn't respond no matter how much psilocybin you gave, or people who needed a lot more, and what your thoughts are as to why some people may be, quote, non-responders?
There's a lot of variation among individuals. It's not really different from other drugs where, it's quite common for there to be several-fold range in dose response in terms of how much it takes to get a certain result. But no, we really don't know. Does that have to do with metabolism or absorption or sensitivity at the receptor level or what? There is a lot of variation, but we don't really know why.
And why diphenhydramine, also known as Benadryl, and was that successful for double blinding?
It was spectacularly unsuccessful in terms of the blinding.
Would you pick something else if you had to do it over again?
Well, I don't think anything is going to be very effective. I think one approach that I think we should look at is to have more of a dose response. FDA will accept dose response as evidence of efficacy, and the low dose could be one milligram of psilocybin or even less. So it's getting pretty close to placebo, but then at least you're getting rid of the expectancy that I got the magic drug, although they might know that they didn't have the magic experience, so there's still that.
What else do we have? Sorry. Why do you think abstinence was achieved at higher rates further out rather than closer to treatment? Was integration continuing into month 7?
So the reason it wasn't really at a higher rate, it stayed about the same, but the difference is if you're talking about abstinence over a longer period of time, then it's going to be lower. So there were people who maybe drank in the first month and then didn't. There were people who didn't drink in the first month and then did. So overall, it stayed fairly flat over the 7 months of follow-up. But if you look just at that last month, you get a better picture of what's going on that month. If you look over the whole, if you're counting people as failures because they had one drink in 7 months, you're going to miss a lot of benefit. So,
definitely. Okay, I would like to thank both of you for your presentations.
Okay, thank you.